This presentation is entitled Implementation of a Brief Childhood Trauma Screening Tool and Trauma-Informed Care Intervention Staff Development on Adult and Patient Psychiatric Units. So for this presentation, we're going to discuss trauma-informed care, or TIC, and adverse childhood experiences, or ACEs. So TIC is a strength-based methodology founded in an understanding surrounding the effect of trauma on an individual's psychological, emotional, physical, and spiritual wellness, with an emphasis toward a survivor's safety while allowing him or her to recreate the feelings of empowerment and peace. ACEs entail a single or multiple experiences or a chronic condition in which an individual is physically, emotionally, or sexually maltreated, or experiences vulnerability or distress that retains enduring adverse outcomes, impeding the individual's ability to thrive. This has an impact on an individual's physical, social, and spiritual wellness. It can also create the fight, flight, or freeze response when a traumatic event occurs, and there's a strong correlation between ACEs and morbidity and mortality. Research shows that there has been notable premature demise of up to 20 years related to ACEs. So this is the ACE pyramid. This was created in 1998 by Folletti and Anda. And what this indicates is from conception to death, there is potential for the ACEs experiences and how they influence health and well-being throughout the lifespan. So should an adverse childhood experience occur, this can lead to disrupted neurodevelopment, thereby social, emotional, cognitive impairment, which can lead to adoption of health risk behaviors, potentially also disease, disability, and social problems, and then potentially early death. So history of trauma. Trauma, specifically psychological trauma, has been a human companion since the dawn of existence. Human response to such traumatic experiences has not drastically transformed over time and has been well documented throughout antiquity. Research surrounding neurobiology and epigenetics reveals that a history of adverse childhood experiences is attributable to societal, cognitive, and emotional deficits. Adverse childhood experiences increase an individual's probability of developing physical and/or mental health disorders, as well as tolerance of health risk behaviors. Research also suggests that adverse childhood experiences can impact clinical symptoms and the progression of illness, as well as treatment outcomes surrounding particular health disorders. This can outline that illnesses have become established in the context of these lived experiences and are biologically distinctive. Background: healthcare disparities. So federal agencies encourage healthcare providers screening for adverse childhood experiences. However, many healthcare organizations do not screen for these experiences. On adult psychiatric patients in an adult inpatient psychiatric setting, these individuals were not being routinely screened for adverse childhood experiences related to this presenter's doctoral nursing practice project. Comprehensive treatment for adult psychiatric patients in an inpatient setting constitutes screening for adverse childhood experiences with every admission. So ACEs can increase the risk of disengaged and ineffective coping strategies with ensuing depression and other mental health sequelae. ACEs refer to 10 risk factors for chronic illness in adulthood, encompassing emotional trauma, physical trauma, sexual trauma, emotional neglect, physical neglect, violence towards mother, household substance use disorders, household mental health disorders, parental separation or divorce, as well as having lived with a household member with a history of incarceration, as identified by a study completed by the Centers for Disease Control and Prevention and Kaiser Permanente in 2013. Dr. Folletti determined there's increased mortality as well as autoimmune, liver, coronary, pulmonary, endocrine, mood, anxiety, substance misuse, and other disorders related to ACEs with regard to the aforementioned research. So lifetime prevalence of adverse childhood experiences. So screening for traumatic events, the research indicates that 61% of males and 51% of females report traumatic experiences in an inpatient setting. The majority of patients in psychiatric and substance use disorder inpatient studies retain trauma histories. At least a third of mental illnesses are associated with childhood trauma, and at least 2/3 of adults treated for substance use disorders report a history of childhood trauma. So with regard to Folletti's seminal study, adverse childhood experiences encroach upon every aspect of an individual's life. Trauma increases risk factors for many chronic diseases and medical disorders. Adults rated their health poorly based upon the number of adverse childhood experiences they had endured from 0 to 10. And time does not necessarily heal trauma. Individuals cannot just get over significant life experiences, such as adverse childhood experiences. Disease and societal significance. Adverse childhood experiences create profound national disease and societal burden. $784 billion per year is associated with childhood trauma. The lifetime cost is over $210,000 per victim, and this can be broken down into over $32,000 childhood healthcare related costs, over $10,000 in adult healthcare costs, and over $144,000 in productivity loss. There's a 10% reduction in ACE prevalence. With this could equate to saving $105 billion annually. So concurrent, time-limited, or frequently reoccurring experiences set the stage for lifetime of vulnerability and trauma as adults. $161 billion per year is associated with untreated trauma-associated substance use disorders as well. So disease and societal significance continued. Increased propensity for interpersonal victimization in women and perpetration in men is related to ACEs. Also, an increased prevalence in mood, psychotic, anxiety, personality, alcohol, tobacco, and non-illicit or illicit substance use disorders. Additionally, there's an increased prevalence with regard to diseases such as asthma, cardiovascular disease, obesity, cancer, diabetes, COPD, and arthritis. So ACEs can create mental health consequences that often arise in late adolescence. There's a lack of healthcare provider screening for traumatic childhood experiences, which can create delayed treatment, lack of holistic care within a healthcare setting, misindications of past trauma, and flourishment of tolerance and apathy. Additionally, morbidity and mortality rates have decreased with prompt screening, preventative measures, and effective interventions if we are screening and therefore treating individuals who have experienced ACEs with this in mind. So practice knowledge gap. Federal agencies encourage childhood trauma screening as an integrated healthcare practice. These federal agencies include the Institute of Medicine, Centers for Disease Control, the Affordable Care Act, Substance Abuse and Mental Health Services Administration, or SAMHSA, the National Councils for Behavioral Health, American Psychiatric Nurses Association, and the World Health Organization. Additionally, the Joint Commission requires trauma-informed care approach with accreditation of behavioral healthcare entities, such as an inpatient psychiatric setting. So with regard to integrated care, this is recommended by SAMHSA and the World Health Organization, and remains the gold standard in the delivery of patient-centric care that addresses the undiagnosed psychological and trauma-related needs in healthcare settings. Practice knowledge gap continued. So with a trauma-informed care approach, this would include a strength-based methodology, an understanding and responding to the effects of traumatic experiences, allow survivors to reestablish feelings of control and empowerment. It incorporates recovery and seeking improvement in well-being and maintaining self-reliance. And it incorporates resiliency in overcoming adversity and managing associated life difficulties. Practice knowledge gap continued. So psychiatric mental health nurses, these are the critical professionals to offer trauma-informed care interventions and screen patients for adverse childhood experiences, or ACEs. They can provide a patient-centered partnership through therapeutic engagement in an inpatient psychiatric setting. They can facilitate the mitigation of negative health outcomes, allow patients to narrate their stories with regard to ACEs, and foster future well-being by addressing past life experiences of trauma. So with regard to this presenter's DMP project questions, this includes, does a pilot study using the Trauma Symptom Checklist 40 or TSC 40 improve nursing staff's level of comfort and willingness to continue screening for adverse childhood experiences? And then, does nursing staff trauma-informed care training improve nursing staff's level of knowledge and willingness to continue the delivery of these interventions? So with the TSC 40 screening tool, the hope with regard to this DMP project was to pilot this screening tool to obtain 120 screenings per power analysis. So this particular tool assesses for childhood trauma of physical and sexual origin and negative associated sequelae. The psychometric testing of the screening tool is robust. It's composed of 40 brief questions that should take a few minutes to complete. It is accessible per public domain. It has existing established validity and reliability in an outpatient setting, however, not in an inpatient setting. So the screening tool has 6 subskills: depression, anxiety, dissociation, sleep disturbances, sexual trauma history, and other sexual concerns. It's graded on a 4-point scale, so 0 being never, 1 seldom, 2 periodically, and 3 often. The total score ranges from 0 to 120. And this scale can discriminate between individuals who have experienced physical and or sexual abuse versus those who have not. So the focus of this DMP project comprised a history of childhood physical and or sexual abuse as opposed to natural disasters, divorce, incarceration, and additional traumatic events that other screening tools are utilized to assess. So the TSC 40 was selected despite its origination in the early 1990s. The DMP project writer provided a follow-up question subsequent to the symptomatology questions to specifically address whether the patient had endured an occurrence of sexual and or physical abuse during childhood by circling the answer with regard to screening. So nursing staff development. With regard to trauma-informed care interventions training for nursing staff, this included a PowerPoint presentation presented to nursing staff. There were CNEs offered for training completion. The training was also catered, and it was videotaped for those unable to attend the live training session. The presentation curriculum discussed evidence-based practice materials that included a history of trauma, trauma-informed care principles, elements, assumptions, and practical tips, the importance of screening for trauma, appropriate method of piloting the TSC 40 screening tool, preventing re-traumatization, and the integration of trauma-informed care into existing patient programming. This DMP project presenter arranged with the chosen academic hospital education department to offer continuing nursing education credits, or CNEs. So goals and objectives. The goals and objectives were to ascertain at least 30 to 35 quantitatively designed pre and post surveys from staff, to pilot the TSC40 screening tool for 30 days. The hope was that this would increase level of knowledge and level of comfort and ongoing willingness to screen for traumatic childhood experiences and offer trauma-informed care interventions. Also, to successfully offer nursing staff training. They hoped that this would close the gap between lack of screening and lack of comprehensive care provision or holistic care. And that the project would provide nursing staff necessary education to afford the provision of consistent, comprehensive care and trauma-informed care interventions. This may mitigate trauma-associated mental health and substance use disorder sequelae, and there's consideration toward integration of the TSC40 screening tool into the electronic medical record. So with the literature review synthesis, what was determined from the research was a clear multifactorial correlation between childhood trauma and abuse, mental illness, substance-related disorders, chronic disease, and increased morbidity and mortality. Also, there was determined to be a higher prevalence and greater severity of trauma, which equaled increased mental health and physical health consequences. So literature review synthesis continued. Adult screening and intervention decreases subsequent morbidity and mortality per the research. Also, childhood trauma screening should be completed with every new patient encounter via this literature review synthesis. And then consistent trauma-informed care should be offered. And what this emphasizes is recognizing recovery and resiliency, emphasizing collaboration and partnership with survivors, maximizing survivor choices and control, respecting a survivor's need for safety and acceptance, emphasizing survivor strength, minimizing the possibility of re-traumatizing survivors, and providing interventions in a culturally competent manner. So Prochaska and DiClemente's trans-theoretical model of change theory was the chosen nursing theory based upon this DMP project, and it includes 6 stages of change. So these entail pre-contemplation, contemplation, preparation, action, maintenance, and termination. This theory focuses on behavioral changes that promote individual, family, and community well-being. Behavioral changes correlated with nursing staff using the TSC40 to assess patients for traumatic childhood experiences, or ACEs. And behavioral change elicited with nursing staff using the trauma-informed care approach on the adult inpatient units was the hope regarding how this theory would be modeled. Additionally, regarding Prochaska and DiClemente's trans-theoretical model of change theory, the nursing staff may transition from a stage of pre-contemplation or contemplation to a stage of preparation or action while participating in the trauma-informed care training and piloting the TSC40 screening tool. Nursing staff remain in a pivotal role to encourage the promotion and maintenance of desired healthy behaviors by effectively screening and providing trauma-informed care interventions. So adverse childhood experiences, mental health, and substance use disorder structural integration into the DMP project. So we talked about the theoretical framework, this being Prochaska and DiClemente's trans-theoretical model of change theory. And the empirical indicator of this project was the Trauma Symptom Checklist 40 screening tool via screening and trauma-informed care nursing staff development via the trauma-informed care training. So with reference to the methodology, this was a quality improvement initiative. The hope was that the nursing staff would attend a live training session or watch the videotape training. This would lead to an anticipated increase in level of knowledge and willingness gained post-trauma-informed care training, and an anticipated increase in the level of comfort and willingness to screen patients post-training and piloting of the TSC40 screening tool for 30 days. So the Trauma Symptom Checklist 40, or TSC40, this is an example of a portion of this screening tool. The question posed to the patients on the unit was, please read the following trauma-associated symptoms and frequency selections and circle the corresponding answers. How often have you experienced each of the following in the last 2 months? So here is the symptomatology of 1 through 20. Examples within this include restless sleep, loneliness, nightmares, sadness, dizziness, stomach problems, headaches, insomnia. 0 being never, 1 being seldom, 2 being periodically, and 3 being often. And then the Trauma Symptom Checklist 40 subskill composition and scoring. This is an example of the scoring here. And it, again, is broken up into questions involving dissociation, anxiety, depression, sexual abuse trauma index, sleep disturbances, and sexual problems. So the total score of the 1 to 40 symptoms was 120, and it needed a benchmark of at least 0.22 to obtain this maximal score. So subjects in sample setting with the DMP project participants, the nursing staff were recruited to receive the intervention, which is training, and screen the patients using the TSC40 screening tool. All nursing staff currently employed were eligible for participation. Nursing staff received random assigned ID numbers to assist in completing pre and post surveys to ensure anonymity of participant responses. The G-Power was used to conduct an a priori power analysis. 30 to 35 nursing staff participants were necessary to detect a medium effect size within this DMP project. The t-test was used to assess the mean score before and after the training to analyze change over time. So nursing staff received information regarding the study, a formal consent, expectation of required time, and a link to the online pre-survey and post-survey. The hope entailed that 30 to 35 nursing staff participants using a dependent sample t-test to detect the median effect size to analyze change over time. And data was not collected or analyzed until approval from the designated IRB, or Institutional Review Board. So this slide is an example of the presentation with regard to trauma-informed care training for the nursing staff that this presenter reviewed with the nursing staff. So what was focused on within this training was, what is trauma-informed care? What are recovery and resiliency? Additionally, we discussed trauma-informed care interventions, psychiatric nursing engagement using a trauma-informed care approach, health and effective coping strategies to offer to the patients on the inpatient psychiatric unit, equity and inclusion, current initiatives that promoted trauma-informed care, and then references. So with regard to the pre-survey and post-survey instruments, these were designed using Research Electronic Data Capture, or REDCap, survey instrument system. So a link was sent to the nursing staff's email addresses to access the surveys. The pre-survey contained formal informed consent and DMP project informational cover sheet. This was a free instrument system, and the pre-survey and post-survey used a Likert type scale type questions. So these questions range from strongly uncomfortable, somewhat uncomfortable, neutral and not sure, somewhat comfortable, and very comfortable with regard to comfort with screening for ACEs, and then range from not very willing, somewhat willing, undecided or not sure, somewhat willing, and very willing to screen for and offer trauma-informed care interventions to clients on the inpatient psychiatric unit. And also ranged from very uninformed, somewhat uninformed, neutral and not sure, somewhat informed, and very informed regarding current level of knowledge. So this is a sample of the post-survey instrument. The first question asked in the post-survey instrument is, what is your level of comfort with screening patients for childhood physical and/or sexual trauma now that you have attended the training? The question number 2 was, how knowledgeable do you feel regarding trauma-informed care interventions now that you have attended the training? Question number 3 was, please rate your willingness to consistently screen patients using a validated screening tool for a history of traumatic childhood experiences with every patient admission now that you've attended the training. And question number 4 was, please rate your willingness to provide trauma-informed care interventions in caring for your patients now that you've attended the training. So with regard to data analysis, this was composed of computing frequency distributions, running the Wilcoxon signed rank tests of matched survey questions, and completing a post hoc power analysis to determine achieved power of each survey question. Data analysis was used to determine statistically significant change over time. So with regard to the data results, 17 participants completed the pre-survey. Unfortunately, with regard to the pre-surveys, 2 of them were incomplete. So this resulted in 15 valid pre-surveys. And then 8 participants completed the post-survey. So we were able to compare 8 pairs of pre and post surveys used with regard to this DMP project. 3 of the 4 survey question responses indicated a positive improvement, and 2 survey question responses achieved statistical significance. Then data interpretation. Statistical significance was achieved with an increase in comfort with screening patients and an increase in knowledge regarding trauma-informed care interventions. Also, a change in positive direction was noted with regard to participant willingness to screen patients. And then there was no statistical significance achieved with participant willingness to provide trauma-informed care interventions. Data interpretation continued. Prochaska and De Clemente's trans-theoretical model stages and process of change. So in relation to the DMP project, participants may have transitioned from a pre-contemplation or contemplation stage to preparation or action stage based upon the results of this DMP project. Participant change in clinical practice through behavioral changes was demonstrated. Participant demonstration of self-reevaluation, social liberation, self-liberation, and helping relationships encounter conditioning was also demonstrated, and a potential increase in nursing satisfaction leading to increase in patient satisfaction, therefore based upon the data interpretation. So with limitations, unfortunately, there was a lack of nursing staff participation in this DMP project. 15 completed pre-surveys of the 17 pre-surveys were received. There were 8 completed post-surveys, and therefore 8 paired pre- and post-surveys used for comparison. In hypothesizing why there was a lack of nursing staff participation, it was noted that at the time of this DMP project, there was a deficiency in nursing staff employed, and also, unfortunately, an increase in staff assaults that may have led to a decrease in participation in this project. So, discussion. The DMP project narrowed a clinical practice gap, thereby promoting a promotion of holistic interdisciplinary team approach in screening for adverse childhood experiences of adults on the inpatient psychiatric unit, as well as offering trauma-informed care interventions. There were predominantly positive and statistically significant outcomes, this being participant increase in comfort and willingness to screen patients and participant increase in knowledge post the trauma-informed care training. A practice change may foster recovery and resiliency through improved management of physical, spiritual, and psychological responses to childhood adversity, use of healthy coping skills, mitigation of negative health outcomes related to ACEs, and the integration of these traumatic events into an individual's life story. The conclusion. Distinguishable increase in knowledge, comfort, and willingness in the provision of screening patients and offering trauma-informed care was ascertained from this project. A statistically significant change over time post-training intervention was noted, and then the provision of comprehensive and trauma-informed care on the adult psychiatric inpatient units, which focused on recovery, resiliency, and the mitigation of associated sequelae. There's an anticipated increase in patient recovery and resiliency and the mitigation of associated negative health sequelae related to the outcomes of this DMP project. And thank you for attending this presentation.